Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspective and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it.
Hey, we are in frigid Orlando.
Florida.
Rainy, 40 degrees. We're in the heart of the polar vortex.
All right, and we have our name tags. We're here. Where are we? We're at a national meeting. Please, we're at the
Triological Combined Section meeting in Orlando here for the next few days. So we're getting to hang out with our friends and colleagues and get some scientific wisdom.
That's right. And I want you to talk for a few minutes. What is your research? What is your area of focus?
Yeah, my focus is all about improving access and improve utilization of healthcare for populations that are vulnerable, that are often dismissed or marginalized or falling through the cracks. I work in Kentucky at the University of Kentucky.
And what is your role there, by the way? I'm
a professor and the chair of the Department of Otolaryngology.
You're 47. You're a professor and chair.
Yeah.
Wow. When did you first take that role?
I'm a sophomore now. So
it's
November
year?
2023. So yeah.
Wow. Congratulations. I'm just so impressed. So you're in University of Kentucky.
Yeah.
And you were saying, you have rural patients.
Yes, indeed. Yeah. Lexington is right on the precipice of the Appalachian region of Kentucky, and Appalachia encompasses about 8% of the U.S. population, but is home to some of the most socioeconomically depressed counties and communities in the United States. And so,
what drew you there?
Well, I've regionally grown up there. I have
Oh,
cultural connections. I was born in Charleston, West Virginia.
Sure.
I did my ENT residency training there at the University of Kentucky. We've birthed 4 of our 5 children there in Kentucky.
So you're a local boy done good?
I am a naturalized Kentuckian at this point.
Wow. So you're from that area, and then you turn this into a research hypothesis. Was something nagging at you? You just saw the social determinants, you saw the bad outcomes. What upset you to turn it into a hypothesis?
Yeah, I'll never forget it. I was a third-year resident. I saw a child with their family in our clinic as a new patient who was 5 years old, was non-communicative, had been labeled lots of different things, autistic, cognitively delayed, and this child had profound hearing loss, and so had fallen through the cracks.
Bilateral sensorineural hearing loss?
Bilateral profound sensorineural hearing loss.
Wow.
And had never had an adequate evaluation.
What year was this? If you're a third-year resident?
Third year would have been 2006.
So, oh my God, less than 20 years ago.
Yeah. So, when you see a child like that, which is sort of like a sentinel event, it affects me as an otolaryngologist, as a future scientist. It affected me as a father.
So you were a third-year resident. So what did you do about that? You got pissed off?
Well, I said, hey, let's do what we can today. Let's do today's work today, and let's prioritize getting some clarity, getting a plan for this family, and then realize that something needs to be done about this. Is this policy? Is this research? Is this humanitarian efforts? And I realized that one of the most powerful opportunities that I had as a young otolaryngologist was to pursue some scientific rigor in this field, to define and describe that this is a real problem.
So when did you start that? As a fellow, as a resident? Did you do fellowship?
I was a fellow at Ohio State in Columbus, Ohio, so in otology.
Okay, because there's only one, the Ohio State.
The Ohio State.
So you're fellowship trained in otology.
Yes, indeed. Yeah. So I spent a year.
Is it changed now? Is it the national change? How do you say it now? So you did a fellowship there.
Yeah, I was a fellow at Ohio State. I did a year of research with Brad Welling, and then stayed on as a fellow there.
Okay.
So I was there for 3 years, and so it gave me time to kind of flourish and grow as a young researcher, thinking about how do I write grants, how do I really become productive in publishing papers, and this interest in health equity and health disparities only blossomed during that time. We were doing work in the bench and other areas of scientific.
You too had done bench work.
During that time, I was doing bench work, but I think my passions were really growing for this health equity and health disparity work.
Wow.
So I
then you
wrote
came
my
back.
first grant as I was leaving Columbus and headed back to Kentucky to start as a first-year
What was that
faculty
grant
member.
regarding?
So that was a grant in which I, impetuously was trying to just fix everything all at once.
Sure.
I thought
The naivety of
we'll do
youth.
tele-everything.
Exactly.
We'll do telehealth. We'll do tele-ABR. We'll do tele-everything.
So this must have been 2009.
So this was 2010.
Well,
when
that
I
was
wrote
pretty
the grant.
pretty ahead of the curve. Everything.
Yeah. The grant didn't get funded.
Okay.
It was a collaborative grant between Ohio State and UK for their CTSA or the Clinical Translational Science Hubs.
Yeah.
And I thought, well, who better poised to get this grant than me? I'm, this
you were humble as a
golden child coming back to Kentucky.
Yeah.
Didn't get the grant, and it was the best possible thing that could happen to me.
Of course.
I went to find the person that got the grant and found that person at UK's campus, and she is an amazing health equity, rural health researcher who is a medical anthropologist and a behavioral scientist. And became, a very key mentor.
Was she senior to you, or she?
Absolutely, full professor.
So they funded the right person.
They funded the right person, but they motivated also the right person to get the mentorship that I needed. Yeah.
So when was your first successful grant?
So my first successful grant was a KL2 or K12 internal career development award.
Yeah, sure.
It validated scientifically what I wanted to do. And in describing health disparities in hearing healthcare for a rural pediatric population specifically. So it allowed me to sort of define the disparity and then investigate some of the causative factors, the barriers and the facilitators of care. And so what that did is sort of got me into the club of research funding, but also helped me to really gather, my scientific ideas and thoughts and channel those more towards clarity on what we need to do next. And that was able to be parlayed into a K-23.
And what was the hypothesis there?
So the hypothesis there was to do a randomized control trial to take what we knew already about disparities that I was publishing on in delays in diagnosis, essentially children from rural communities taking 2 times longer than urban children to get diagnosed for hearing loss.
Wow.
And then how do we take maybe a culturally acceptable intervention? We use patient navigation, sort of out of the cancer oncology world.
Genius.
And modify that for infant pediatric hearing healthcare delivery, and launch that in our center, as well as a partnering state-funded health system that provides diagnostic care for infants. And so that small RCT demonstrated a dramatic improvement of adherence from failed newborn hearing screen to follow-up in the audiology clinic to receive diagnostic testing, diagnostic ABR to either confirm normal hearing or to identify hearing loss. So we improved the adherence, from around 68% to about 93%.
So I'm going to keep our momentum going because I have a feeling you could talk about this forever, and so could I. So you took a nurse navigator to go to a child that had been diagnosed. Quickly walk me through that.
Yes, so actually it wasn't a nurse navigator. A navigator, as we define it, was a lay person.
Oh, wow.
That was someone who had experienced this healthcare
trusted advocate
problem. And so this is someone, a parent of a child. Most often it was mothers who were willing to be recruited and work with us as a navigator.
Parent of a child, who had gone through this.
Who had gone through the early hearing screening.
And so what do they do then?
Testing.
How would you get, let's say I'm in rural Kentucky or Appalachia.
Yeah. So we would recruit them and hire them as a navigator to work in this research.
Brilliant.
We would provide some training that stemmed from George Washington University's patient navigator program that they use for their cancer center. But using sort of cancer agnostic training modules would teach them professional barriers about education, about supporting.
And then
people.
How would they know where the kids are? How did you all know?
So we were able to receive them once a child was referred from the newborn nursery for follow-up testing.
So an outlying newborn nursery, they get a referral.
Yeah. Then we would make a connection, recruit them into the study, and they would be randomized to either control condition, which was standardized automated phone calls, an appointment mailer, or to the navigation in addition to the standard of care.
So the double time that you noticed in your randomized controlled trial wasn't from the newborn hearing screening. They were getting screened. That referral was getting made. Then for whatever reason, social determinants of health,
Yeah.
working, inability for transportation, communication, they wouldn't get in.
Right.
Got it.
Right. Yeah, they fall through the cracks, and they just, children in rural communities were being diagnosed with their hearing loss about 7 months after birth on average.
Versus 3 months.
Versus about 3 months in the urban, and that's the recommendation, all screening done by 1 month, diagnostic testing for infants by 3 months.
That's the standard. That's
Yeah,
thank you for that.
EDI standard, and then some type of intervention implemented by 6 months of age. So
wow. So we had missed that.
we were missing those targets completely.
Many people have said this, including my late father. Some of the biggest jumps in technology are the simplest when you look backwards. No offense, but that is exquisitely simple, but genius, right? How do we have trusted advocates going out there? I want to watch our time because I know you have to get back to where you're going. How's that boy doing, that 5-year-old?
Well, he's has a cochlear implant now.
Okay.
He's, has received, education. A lot of children that receive cochlear implants or care very late, especially in Kentucky, they may not continue in mainstream school settings.
Yeah.
They often will fall towards a school for the deaf or
Of
go a
course.
different
Where's
route
this
of
young man
communication. So he's still in Kentucky.
Okay.
And kind of lost contact
Sure.
with him as wasn't my patient as a resident.
He's probably a young man.
But a young man somewhere, and many communities are not very friendly to those that have health conditions or have hearing loss, and certain rural conditions or rural environments. It's just might be difficult to find employment.
I keep getting chills because I think of him as the index patient that has helped hundreds of kids in rural Appalachia, Kentucky, and West Virginia. That's truly amazing. You also have an academy role.
I do indeed.
Would you?
Yeah. So I'm the coordinator-elect for Research and Quality, the Academy, which is a dream opportunity.
It's a dream for me to have you.
Yeah.
What a good 90 days for me.
We're a dream team to get to work together. The reality is this position is about promoting the rigor of the science that the Academy is committed to, whether that's through core grants or perhaps that's through dissemination of important contributions to science through our synthesis of clinical practice guidelines, and trying to inform our constituents who are otolaryngologists, to inform policymakers, and most importantly, to provide information for patients regarding what we do.
I love your lens, and Dr. Vikas Mehta has been in that role and has done a fantastic job. So you have some great shoulders to stand on.
Some big shoes to fill, because Vikas has really been an amazing partner and a mentor, in kind of showing me the ropes. And we've got an amazing team at the Academy.
We sure do. They're awesome.
Chris Schultz and
leading
rest
terrific
of the,
folks.
administrative team who are leading quality and research efforts. And another important aspect of what we do in research and quality is Regent, and being able to harness the power of electronic medical record
macro
capture
level data,
and be able to find really key trends and directives in how we care for patients, where we can improve efficiency and effectiveness of our care, and also then how we can influence the future of research agendas and where our public health needs are going in the future. And unless we're looking, we're really missing things. And Regent's going to give us the opportunity to do that.
Yeah, one of the joys in my role is the diversity. You and I are completely different people. You're scientific, thoughtful, and methodical, and I'm just out there going crazy. So I love that we have you as a volunteer member, right? I mean, you're spending a lot of time, and it's my huge honor, and our specialty is blessed to have you. So congratulations on that.
Thanks.
What is the University of Kentucky sign when we sign off? What's your like? So Hookem, I think, is text.
Go Cats.
But what do we do? Like go Cats?
People usually do this.
Wait, let me see.
People usually do this.
What is this
which maybe is like a K, but it's also the inverse of Louisville.
Okay, so this is how we're going to sign off right here.
Yeah.
Well, I'll congratulate you. Huge honor. Thank you
Yeah.
for what you do for the Academy. And it's
Yeah.
inspiring that you're taking a simple concept to a macro level. And I say simple, not insulting you. There's a beauty in simplicity.
Thanks.
Any final message to our Academy members? I'm just inspired by your recognition and your work.
Well, I'm honored to serve, and we've even as we've been at this meeting, we've heard about gratefulness and gratitude from some of the leaders in the field, and that's today's a good day to be grateful, and today's a good day to be intentional in what we do scientifically or relationally. So I'm thankful for the opportunity to serve our academy and support you.
Right on. Thank you.
Thank
Thanks
you.
so much.